Our next speaker is Dr. Mattia Glauber. He will discuss sutureless valves. Dr. Glauber.
Thank you for the invitation. It's the first time here for me in Houston, and I'm very glad and honored to be again here. My topic is on sutureless valve, and it's obviously an important topic. A lot of things to say, and I hope to keep everything in time. So why there is a need of a new type and technology of valves in the area of TAVI? We have seen this morning all this interesting data. But surely surgery still exists and will need to improve the results in surgery, and we can do it reducing the cost-clamping time, cardiopulmonary bypass time, which is very important, especially for minimal invasive setup. We need to improve all the outcomes, and we need to optimize the surgical approaches, especially in a particular situation like concomitant procedure. We need to standardize and to reproduce the procedure so that the new trainees can do it with a less number of procedures, so as to shorten learning curve and educational programs, and obviously to facilitate minimal invasive AVR, because we have seen in many papers that this can improve the outcomes. There is an important, impressive growing in publication. You see here that there is a quite difference in numbers of papers per Perceval Intuiti, and there is an important moment in which we have the outcome for a consensus paper that give us some recommendation. These are the valves that are on the market, and one was on the market, Enable was retired in 2015, and probably you know some of the characteristics of these valves, but you see that Intuiti got the CE mark in 2012, Perceval in 2011, and both are bovine pericardium. Enable was equine, and they are available in most of the sizes, and other characteristics will be explained later. The two major characteristics that I intend are important is from the concept of the design, which reflects the technique of implantation. Perceval is mounted on a nitinol elastic collapsible stent, while Intuiti is mounted on a rigid cobalt chromium steel structure. And obviously for here we have some advantages. It's totally sutureless, and here we have 3 sutures that fix in concomitation with the expandable portion of the valve, which has which needs a balloon expansion, and is anchored either with the cuff and the 3 sutures. The Perceval is anchored with a strut with a homogeneous stress distribution, and with the inflow part, which is anchored at the annulus. So here we have a more homogeneous stress distribution, which is also in the sinus of Valsalva, and here the valve is anchored only at the level of the annulus. So 2 different concepts of working. We know that indication is for all operable patients, and with different even risk stratification. And this valve in the first publication was more intended to be implanted in either this cohort of surgical patient as higher risk, and after, in the past years, we are implanting this in all type of patients. Indication for use, we see that it's indicated in the diseased aortic valve, and there are some few contraindications for Perceval, which are disease of the aorta, like aneurysmal dilatation or dissection of the ascending aortic wall, hypersensitivity to nickel, or anatomical characteristics that are described there. And the valve was in the first, or still in Europe, it's not indicated with an age less than 65. This is a very recent paper. This was published a few days ago on the American Journal of Cardiology. And this paper is comparing with a propensity match study a group of 1,000, approximately 1,000 rapid deployment valve out of the Gary registry, compared with the database of the Gary, which is a German registry for aortic valve disease. And we see that this paper reports this type of elevated rates of pacemaker implantation, of disabling stroke, and postoperative higher hemodynamic gradients. So this paper, in my opinion, has a lot of contradiction, and I would like to present you some other data, and later on, if we have time, we can even discuss better this paper. So, learning from experience, who can benefit most of this type of valves? We have three types of situation in which we have patients who are sensible to a longer cost clamping time, in which we need to reduce the cost clamping time, patient who has particularly necessity to recover faster, or technically challenging situation. And we see that diabetic patient with low ejection fraction, older patient, obese patient, patient who need a less traumatic procedure, who has a calcified root, small annulus, redo, particularly interesting, combined procedure, single valve plus CABG or mitral, or patient who has multiple risk factors. All these situations are good indication for a sutureless valve. And there are obviously different publications in which all these aspects are covered, like in concomitant, like in redo, small and calcified annulus, even porcelain aorta are in non-suitable for TAVI patient, also a good indication, like degenerated homografts, which are young patients. And these have excellent benefits due to the ischemic time reduction, the lower mortality, and greater hemodynamics are all indicated in this paper. But after initial numbers of publication in 2015, a consensus paper was published, and the objective was to provide recommendation on how to start a program for sutureless and rapid deployment, to provide recommendation on indication and contraindication in respect the stented valves, and to share some technical issue. 37 experts out of more than 30 centers, and we published or we described some indication which is an alternative to stented valves, and all the aspects indicated before: redo cases, fragile aortic wall condition, calcified root, porcelain aorta, prior implant of aortic homograft or stentless valves. These are all good indication. can be a first choice in case of concomitant procedure, is possible in bicuspid type 1 and 2, but it's contraindicated in type 0, and in case of abscess due to destructive endocarditis. Key technical recommendation, proctoring is important. Complete and careful decalcification of the root is also very important. Oversizing is absolutely not beneficial, even detrimental, and I will show you why. And in case of multiple valves, there are some key points that are described. We can discuss them later. And even from the, I don't know if the video is running. Yes, from the consensus, there was an indication that CT scan can give you a lot of information for the implantation, sizing, choice of approach, minimal invasive, right thoracotomy, mini sternotomy versus sternotomy. These are all indications that can be pointed out with the CT scan. And this was also recommended. Another important recommendation was a complete decalcification to avoid paravalvular leakage and to remove all the extensive calcification, but carefully to don't create annular defects, which needs to be solved. So this portion is a portion in which the collar of the valve has to be implanted. It should be supraannular, reason why the 3 guiding suture has to be transannular, and this are even published as a key point for avoiding paravalvular leak and to reducing the rate of pacemaker. And you see that the paravalvular leak are not higher than the one we can observe in sutured valves. We have that for Intuiti 1.4 in the Triton study, 1.4 even for Perceval in the multicenter, over 700 patients implanted. And we know that, and we see it in this slide, we have that in standard valves, the PVL rate can rise from 1 to, sorry, this is a pacemaker implantation. It's the next slide. Sorry for the confusion. We can see that the PVL can be very high, especially in reoperative surgery, which can rise from 1 up to 11% from 4.3%. So this is a rate published in the European Multi-Center, over 700 patients for Perceval, 6%, while 9.5% for Intuiti. This is in the Transform trial. It's similar for the Foundation. I am the principal investigator of Foundation's trial. More than 500 patients. We have a pacemaker which is around 7%. So we remember that transcatheter valve has a higher pacemaker paravalvular leak rate. And let's go to the hemodynamic performance, which is very interesting. It's permanent over and stable over time. These are the data of the gradient at up to 5 years in the different size. You see that the gradient is independent from the size that we implant. This is important because we know that we are really expanding the valve in the LVOT, and we are using all the LVOT of the valve. And these are the gradients, the mean gradient compared to conventional valve, which are in favor for sutureless valve, and the same is at the follow-up. We have in this paper, you see that over time the results are stable and still in favor of the sutureless. All this data brings also good outcomes in terms of mortality when we shorten cross-clamp time, when we have good hemodynamic performance. This brings also to improving data on survival. If we compare also with TAVI, there are different papers in which we have a superior result in data on survival compared to TAVI. I personally published 2 studies on this, and in the first experience, I even was the surgeon who implanted TAVI, so the outcome was, in my hands, better in the surgical group of patients. And durability has shown promising results. Here we have, for Perceval, 2 studies at 5 years, and 3 years, Intuitive at 3 years. We see that the structural valve deterioration is 0%. And performance and durability are really correlated. You see here that one key point for implant is that after implant, we reobtain a perfect circularity of the stent with a linear distribution of the leaflet, which corresponds to a regular opening and with low gradient. Look what's happened when we size up the valve. On the left side, you can see how the leaflet are moving if we downsize for one size, or and on the right, when we do it with 2 sides up, you see that the leaflet are totally waved, and the effective orifice area is reduced. This is the cause of some reports on higher gradients and even of the fluttering of the leaflet at echo. And I'm sure that also in the few cases of early degeneration, this is the cause of the early failure of this few reported valves. This is one of the problems that can occur when we oversize. The valve does not find the place in the annulus, and it has to invaginate. And this can be the cause of an important paravalvular leak and central leak too. So this valve has either to be removed or to be, in 3 cases I know, a TAVI was successfully implanted. Related to durability, another important aspect is that the valve is not crimped, but only collapsed. And this is what happens when we put the valve in the collapsible tool, and reducing the size obviously improves the visibility during deployment. And this is, in my opinion, important aspect for minimal invasive procedure. The atraumatic collapsing was even evaluated with histopathological studies in which no damaging of the pericardium was observed. But we know that even other valves can fail earlier, and this is also described for conventional sutured valves. I don't enter in the details, but when we have a structural valve deterioration in an early phase, what is feasible and was done in vivo, but was evaluated in vitro, we can obviously implant a TAVR. And we can see that the elastic stent of Perceval can even gain one size compared to the here is a case of the Magna is 19 versus the Perceval S. Here we can implant a 23, and here we have to implant a 20 Sapien. So another consensus was written on the advantage in terms of minimal invasive. In the afternoon, we will have the cadaver lab, and this, in my opinion, will be the point moment in which we can discuss all the benefits. Collapsibility is the greatest advantage for a very small access, and this was even proven as superiority in a high-risk group of patients, in which you see the mortality was quite low in this group of high-risk patients. And here a very short video, but we will have the cadaver lab this afternoon. You probably have seen all these kind of videos. There are even studies in which the economical advantage is evaluated and studied. I am publishing a paper in which it compares the economical advantage of right thoracotomy with Perceval versus TAVI. This, I hope, will be soon published, and these are my conclusions. So, sutureless are a promising alternative to standard surgical AVR. An important randomized study is ongoing, the PERSIST AVR study, in which we compare sutureless versus sutured. Perceval surely shows the broadest clinical experience, confirming excellent performance in terms of clinical results, durability, and hemodynamic performance. And probably this may become the new gold standard for surgical AVR in the field of biological valves. Thank you very much.
Thank you, Dr. Glauber.